When any of these organisms is producing an enzyme called carbapenemase, it's labeled as a CP, carbapenemase producing, let's see, CRAB, or carbapenemase producing CRE, or carbapenemase producing CRPPA. Cases locally, but definitely other counties in the Bay Area and Orange County, they have their own share of this very resistant fungus that's usually much harder than the regular bacteria to spread, and it's much harder to find some antimicrobial that will be able to eradicate it. These multi-drug organisms are labeled as similar to the COVID. You know, COVID has been labeled as a novel virus. Why it's a novel? Because it's never been encountered before. You do have the coronaviruses, let's see, that gives you a common cold. These called endemic, meaning it has been present, we've been exposed to it, and now when you're having a new class of virus or bacteria, then in an area that has not been encountered before, it's called a novel. That big example of this, influenza, for example, right? You have these endemic influenza, seasonal influenza every year, and suddenly you have a new strain that comes in. That applies to the same concept with these novel bacteria. So novel bacteria, CRAB, has been on the news since at least just before COVID or around the start of COVID, where start having this new organisms that has not been seen before, highly resistant, highly transmissible. So if you look at this link, which will be provided these slides at the end of the lecture, this link, the CDC in 2019, just before COVID started, they labeled these organisms, they gave them different tiers, tier 1, 2, and 3. And tier 1 is, tier 1 and 2, these are the novels one. Tier 1 is mainly you're having a bacteria that's resistant to every antibiotic you could find. And these are something, again, never seen before. Tier 2 is the one, let's see, CRAB, especially the NDM class, where we're seeing. These are mainly, has been seen in parts of the country, and let's see, suddenly they are new to California, for example. These are called novel viruses, novel MDRO. Endemic MDRO, these are your typical MRSA, VRE, the stuff that you see on a daily basis in the hospital or in a skilled nursing facility. Why do we have resistant organisms? Overuse of antibiotic is that simple. Anytime you're giving somebody antibiotic, there's maybe 1% resistant bacteria of that strep or staph resistant to that antibiotic. The more you throw these antibiotics, guess what? These strains will multiply and they'll become dominant bacteria for that host when that patient comes back to the facility. You see, I'm sure you see these cases more and more in skilled nursing facility where you have UTI, and this E. coli was good today, and then the patient continues to have UTI after UTI, and suddenly that Keflex doesn't work anymore. So this is unfortunate kind of price we pay for overusing antibiotics. The more antibiotic you use, the more resistant strains multiply and become the dominant player down the road. Bacteria has different way of getting resistance to antibiotics. They could modify their DNA or RNA and produce certain things in the structure of the bacteria that either limiting how much antibiotic could come inside, or more important than this, it's the enzyme. So when a bacteria producing certain enzymes, in this case, let's see the carbapenemase, this is much powerful way of killing any antibiotic before or after the antibiotic is in the environment or surrounding that bacteria. And one major way of resistance is using the virus. You know, these viruses that you have on a regular basis sometimes could be a third party helping transferring certain resistant genes from one bacteria to another. Sometimes you see patients you know, they never been in a hospital setting. They come in and they have like UTI and E. coli resistant to everything. And you scratch your head, how did this patient, who never had antibiotic before, who never been in a healthcare facility before, had resistant organism? Well, it's that simple. You know, if you've been a roommate to a certain patient, um, potentially you could have a gene that transferred from that patient who had, let's see, infection with MRSA to this patient. This is one example why, let's see, screening patients going to a hospital there from a nursing facility. Usually it's recommended, let's see, do an MRSA screening. But viruses, they tend to play an audio role there between bacteria, transferring one resistant gene to antibiotic from one bacteria strain to another. Uh, Antibiotic resistant could be also related not just to the antibiotic that we give our patients, it could be related to antibiotic you give to the chicken to make certain breeds of plants or animals, in theory, much better. So the minute you're going to have more resistant bacteria in these animals, humans going to get exposed to them and develop these resistant bacteria. Don't want to go over the details. How did we go over the evolution of this antibiotic resistant? But anytime you had an antibiotic that invented, starting with the sulfa and penicillin antibiotic, it didn't take longer before we start seeing more and more resistant strains of different bugs to that particular antibiotic. And you could see starting early 1930s, going all the way to where till 2020. So the last one here you see in 2020, this is a local hospital in New Jersey. They have COVID outbreak, acute care hospital, and then they start seeing these cases of these Acinetobacter, which is usually encountered in healthcare settings. It's rare, but they had significant number of ventilated patients who got infected with these Acinetobacter strains, and these were pretty resistant to most of the antibiotics, and it became an outbreak. So this was kind of the beginning of this tide of Acinetobacter or CRAB cases that spread from the East Coast, spread nationwide, including in our state. Beta-lactam antibiotic, just to give you some idea about the boring stuff when we hear beta-lactam. Beta-lactam is this structure, the chemical structure from back in school, if you remember the antibiotic and penicillin. It has a nitrogen, oxygen, and carbon structure there. So beta-lactamase is mainly an enzyme that breaks this cycle. So beta-lactam antibiotic, as I said, it involves penicillin, cephalosporin, monobactam, azithromycin, and carbapenemase. And beta-lactamase works again when you say beta-lactamase, it could be penicillinase, which affects the penicillin family, could be cephalosporin or ESBL, and it could be carbapenemase, where it affects the carbapenem antibody. And you could see here the evolution of these beta-lactamase, that this is not something new, but the ESBL, which is a cephalosporin beta-lactamase, and now the carbapenemase just started just recently. And the carbapenemase, just to confuse you more when you see these cases, especially these fancy kind of terms here. So the NDM is the one that started, or when you have any of these CRAB antibacteria, and they have these 5 major carbapenemase, it has different way of transmissibility. So a CRAB strain that has NDM, the NDM stands for New Delhi metallobeta-lactamase. This is what you could see from it was initially detected in New Delhi, so they call it NDM in 2008 in Sweden, but it was mainly a patient who acquired in New Delhi. So this is much more resistant or highly transmissible contagious strain. And this is the one we have been dealing with in Fresno. The other one is the oxacillin carbapenemase. You could see also that these are relatively new things. So the one that we're dealing with in California and in Fresno is mainly strains that harbor NDM and the OXA23, which will be in touch with other slides. Why do we care about the MDROs? We care about them for two reasons. Number one, if you get infected with these, if you, let's see, colonize with it, there's potentially you could get infected with it. And if you have very little antibiotic to cure it, then there's high mortality for that patient. And number two, it's contagious. This is not COVID. It's not like contagious like COVID, but definitely it could put people at risk who share the same environment, either a roommate or a bathroom and so forth, could put them at risk to acquire this MDRO. And this distinction between colonization and infection becomes there's a fine line where you could have, and unfortunately, most of these multi-drug resistant organisms, we don't hear about them unless they go to a hospital, right? Or you test a patient who you think sick with some bacterial infection, and the culture will tell you this patient had MDRO. But, you know, before this patient reached that clinical stage where they got sick with that organisms, there has been cases that people were simply colonized, meaning they carry the bacteria and they're not sick from it. Now you're dealing with the tip of the iceberg. So the infection is up there, but you're having unidentified large number of people colonized with this particular bacteria. MDROs, unfortunately, also they tend to affect people, not healthy folks from community and so forth. They tend to affect people who reside in skilled nursing facility, who has multiple tubes and dualing catheters, chronic wounds and so forth. So these patients at baseline, they're sick, they have a fragile immune system. And these MDROs simply will have definitely high mortality and mortality on those kind of patients because the type of patients to start with are not that healthy. And, you know, at least if you look at the CDC guidelines with infection control and so forth, starting from 2007 until they revised their infection control measures in 2019, there have been more emphasis on mainly stopping this transmission where people go between different facilities and you're having a healthcare worker who mainly will be a vehicle to transfer this particular organism from one patient to another, hospitalized, going back to skilled nursing facility, physical therapy, and so forth. So this issue of transmission between healthcare facility requiring communication and so forth has been a critical kind of element to break this vicious cycle. Most of these patients with multi-drug resistant organisms, they get colonized, and the area or the source where you got colonized also becomes different. MRSA, for example, as you know, it affects your nails, sometimes the skin. Gram-negative organisms like the Enterobacters, to some sort, Acinetobacter could affect your skin, your GI tract. So in 2007, the CDC, if you look at their guidance, they had the big distinction between two kinds of infection control: a standard precaution, where you simply it applies to any patient in a hospital setting or healthcare setting. A patient who comes in today for sniff, doesn't have any history of documented multi-drug resistant, you put them on standard precaution. What that means, you cannot change their line. If they have a line, you have to put gloves or gowns. But other than that, you do not require, besides the hand hygiene, you do not require any specific, with your daily communication with the patient, specific PPEs. The contact precaution, on the other hand, is much more for people with known MDRO. And these are the folks that every patient comes to the room, any healthcare personnel comes to the room, they need to put a gown, glove, they need to wash their hand or do the hand hygiene before and after. And those patients are usually restricted to their rooms because they're under contact investigation, so contact precautions. So most of the time, this has been relatively good in preventing certain transmission, but it has been bad also because it has a price of restricting those patients to their rooms. And we know with COVID, right, that this isolation of patients, it might be good in the physical perspective of things, but it has definitely a mental perspective with the mental health there. So now in 2019, the CDC came in with new approach to stop the spreading of MDRO. And this is, they kept the standard precaution, which is mainly you do hand hygiene, you're putting gloves and gowns when you're dealing with a wound cleaning, a line cleaning, changing your catheter, changing your line. And then the contact precautions, which is mainly the same that we discussed. It's mainly patient stays in their room, a patient with C. diff, a norovirus, you need to wash your hand before and after. You need to put gown and gloves. If they have some sort of droplet precautions, pneumonia and so forth, you need to be masked and to put an eye protection. And then in between comes this new, which you might heard of it or not, and there's this more push to use this in skilled nursing facility. This does not apply to a hospital setting, so this is much more for skilled nursing facility and long-term facility. And the CDC call it enhanced barrier precaution. The CDPH call it enhanced standard precautions. So different two faces for the same person, but it's much more that if you have a patient who's at high risk to get MDRO, and these are the patients with bedridden, multiple lines, catheters, a bad open wound, those are considered, even if it's not proven that they have multi-drug resistant organisms, that at higher risk for that. And they might be the bottom of that iceberg that the other slide showed. They might be harboring these organisms. So anytime you're dealing with a medical care, direct care for that patient, it's better for you to have a glove and a gown. But those patients should not be restricted in the room. They could go outside as long as they don't have an open wound that might be spreading these organisms. Even if you don't have a proof they have the organisms, as long as they have good hand hygiene, they don't need to be restricted in their room. And these are the type of the patient we discussed, mainly high-risk patients. So standard, enhanced standard, or enhanced barrier, and transmission-based, which is the contact mainly in our discussion, the three different one. And the standard is the middle one, where you're having somebody who might have a novel virus and not an outbreak setting anymore, or might have potential risk factor to acquire these organisms. Then they put them on enhanced standard precautions. And this is kind of the same from the state. It's kind of, these slides will be available for you at the end anyhow. You could go through the details. And the state mainly, there's more push that for those high-risk patients that might harbor these organisms, you put gown and gloves when you deal with these 6 elements of care, cleaning their environment, direct care, toileting, and so forth. Even again, these are patients who are at higher risk, but they do not have confirmed organism, but we're assuming they potentially might have it, although they were not tested. The carbapenemase, the CRAB, quickly I will go over its environmental pathogens. So the difference between E. coli that you have in your GI tract is part of the GI flora, and Acinetobacter. Acinetobacter has never been a human pathogen, meaning we don't have it in our skin like a staph. It doesn't live with us. This is something you have in the environment, and it loves healthcare facility for different reasons. If you look at the statistics for the CRAB in California and in nationwide, you could see that the CRAB has been much more resistant. And even these statistics from 2 years ago, we're having much more carbapenemase that with these strains of and you could see the Acinetobacter has been almost the dominant strain of these multi-drug resistant bacteria here in California. And these numbers, as I said, a little bit older. You could see since the COVID started, cases in California has been on the rise. And again, this is an older slide. In Fresno, we start seeing the cases in April, but much more higher now. As expected, most of these cases with especially the NDM, which is the type of carbapenemase that will be more contagious when the strain of the crab harbor this enzyme, has been much more in these skilled nursing facility. And especially there, the concern was the ventilator or the subacute facility. Here in Fresno, just to give you some idea, 11 cases has been in one of our subacute. Another subacute had a CRAB, but it was not carbapenemase producing. A hospital had one case, and random facility had 1 or 2 cases here and there. Just to touch base with these element of when you have a CRAB, these cohorting these patients becomes very critical. So if you're having a CRAB with the same enzyme, those patients could be cohorted together. That becomes easier said than done sometimes. You have limited space. Most of these facilities, they don't have like a private room and so forth. So this becomes a little bit complicated when you're dealing with cases coming from a hospital setting, or you have more cases in your facility. But cohorting becomes, like COVID, an important element to decrease the spread of these organisms. And much more than that is communication between different facilities where these patients, especially the one with different lines and medical care and complicated issues, they move on regular basis between the acute and the subacute and the SNF facilities. This probably most of you know, if you have a patient with CRAB or MDRO, this form, the link will be provided there if you don't have access to it, that needs to be kind of communicated verbally and to if the patient is moving to a hospital setting or the other way around. And terminal cleaning. So this becomes pretty critical as well. A patient with CRAB leaving the facility, either a hospital or a skilled nursing facility, it's very important before you place another patient in that facility, in that room, that a terminal cleaning should be done. Acinetobacter tends to be pretty resistant and could stay on a table, bed rails for some time if you don't really clean these high traffic areas before the next patient comes in. Communication between facilities becomes very critical, as I said. And putting these patients, to give you an idea, especially for the facility that had not been dealing with cases of CRAB. Usually when you start having a case, then you start doing PPS, point prevalence survey, which is mainly a contact to that patient, a roommate, or somebody who shared the same bathroom. They need to be swabbed. And you do this, the same thing we did with COVID, right? Where you're testing on weekly or biweekly and so forth. Over here, these PPSs are done every 2 weeks. And the outbreak is considered to be over when you have 2 rounds of these biweekly PPSs with no new cases. And I could tell you, you know, probably some of the facility online, I mean, they probably could tell you more about these. Like, it becomes very frustrating the minute you kind of have a CRAB case in your facility and kind of the infection control measures are not up to date. This could spread. Again, it's not like COVID, but you could have these cases that could linger for some time. You could have a PBS done on the high-risk patient or considered to be like at high risk to acquire this infection. 2 weeks later, you start having cases. And so it's a slow but continuous frustrating transmission in the facility. And generally speaking, those are not the same thing. I mean, we've seen with COVID before, right? I still remember when the whole COVID started, there was resistance to accept these COVID patients. These MDROs, they're not really that complicated when it comes to their care, in the sense they can require contact precautions and so forth. But the issue with the private room sometimes pops in, but they're not really anthrax or highly tuberculosis cases. It's mainly just a simple infection control measures that you need to care for these patients and make sure they don't spread it to other folks. And the patient then screening the other patients for CRAB. When you identify a case, we usually tend to screen the roommates in a hospital setting or in a SNF facility. Some of these rooms, especially in SNFs, they might have two separate rooms sharing the same bathroom. So if they share the same, if there's an epi link, by sharing the bathroom, these other folks considered to be also exposed and they need to be screened. And anytime you're having a CRAB case in a hospital or in a skilled nurse facility, we go back for 30 days. Usually the magic number for stopping the outbreak or going back is the 30 days. So I guess something to do with incubation period to get colonized and infected and so forth after an exposure. The same thing happens. There's more emphasis also on these patients. If you're having somebody who comes from another country, who's hospitalized, let's see, somewhere, and now he comes in within 12 months to be hospitalized, those patients should be screened for a CRAB. CRAB is pretty common in other countries, and it's considered to be a risk factor for them to have this if they've been hospitalized somewhere overseas. The screening of the contact becomes a little bit complicated. And this is kind of where I highly suggest that if you have any case, is just to call us. So at least we could direct you what kind of testing needs to be done. If we're dealing with an OXA23 cases, and this is one of our biggest outbreak and one of the subacute, where the testing, it's usually complicated because you're going to need to do swabs of the skin folds, and you send it for a culture. So you mainly looking for Acinetobacter growing in a culture setting, because the carbapenemase, the testing that we do for carbapenemase, does not detect the OXA23. And if the culture is positive, then those will be tested for the carbapenemase in some special public health lab, mainly Washington University up in Seattle. If the original case is NDM, which we had also cases in Fresno, mainly in one of the SNFs, then a PCR screening, and these are rectal swabs. Most of the CIFIAD based testing, they do this. All the hospitals in town, they do have this testing. Commercial labs, they do this testing. But again, sometimes you will be surprised because you might have a CRAB case. You do the PCR testing and the PCR comes back negative for carbapenemase. That does not mean that the patient does not have carbapenemase. It means that the carbapenemase that was tested was not simply detected if the case was OXA23. So for OXA23, that's important, I think, to communicate with public health, because if this patient comes from a facility that has outbreak of OXA23, then the testing for these roommates will be different than if they harbor the NDM. The carbapenemase testing, as I said, you could look at this table later, but it's the OXA23 is usually requires a culture rather than molecular testing. The NDM requires much more molecular testing. Since running out of time, the reporting, this is the phone number for our communicable disease division here. So if you're having any case, most of these CRAB cases or CREs, they come in a CMR, and usually we know about them from the lab directly before even you're aware of it in your facility. But in general, if you're having a CRAB case, it's required that you communicate it by a CMR, and this is the phone number to call to see who should be tested and who should not be tested. Sometimes the question comes in, somebody comes to this hospital, they have a CRAB, what do you do with the roommate? The roommate has been discharged. Should I test the whole floor? Should I test if the patient was not on contact precaution before the CRAB was identified? So all these questions could be answered by looking at the cases and the epi link between different patients on the same floor. And this is a health officer order that or alert that was kind of a few months ago with attention to the CRAB cases that we had. Since then, we had no outbreaks anymore. All the 2 outbreaks that we had in our SNF and subacute rehab has been closed, which is good. These cases of CRAB in other SNF facilities out of the county, are communicated usually with the IP at the hospital or SNFs, because most of these patients who are transferred from a facility that is dealing currently with an outbreak will need to be placed on contact isolation, awaiting for a testing to clear them out of the isolation. So these facilities, usually I believe it was up to 2 or 3 last week, are communicated with infection control. So any patient comes from this facility will be labeled for contact precautions and testing if needed. And these are the resources that links mainly for CDPH, HAI, and the CDC if you're interested in getting more information. And open for questions if any questions there. Yeah, these slides will be shared shortly after this with the whole group, just to get more. Sorry, I didn't go in details of some of the slides, but you could read the links or the detailed slides for more information. Okay, if there's no questions, please just keep that number with you if you have any. Hopefully you don't have any CRAB cases, but if you have any, just make sure to communicate with us and we'll guide you how to go to the next step. Okay, take care.